Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
It's Lindsay Smith Rogers. Today, what's happening with NIH funding for scientific research and, more broadly, the future of the partnership between universities and the federal government? I speak with Dr. Jeremy Berg, a former NIH Institute director who has been closely following the changes since January. Let's listen. Dr. Jeremy Berg, thank you so much for joining us on Public Health on Call. Would you start off by giving us a little bit of background about you and your work?
Certainly. Well, first off, it's a pleasure to be here. So I was actually at Hopkins for a long time. I started off my career as a postdoc and was on faculty first at Homewood and then in the medical school. So I have roots in Baltimore. I left to become director of the National Institute of General Medical Sciences at NIH, which is one of the 27 institutes, in 2003. And I spent there from 2003 to 2011. And then me and my wife, who's a Hopkins MD PhD alumna, moved to University of Pittsburgh, where we've been ever since.
And so today we're going to talk about NIH funding. You've been really following this closely for the last year or so. Would you talk to us about where the overall ecosystem of scientific research funding is at this moment now and what contributed to where it is?
Sure. So I was in a somewhat unusual position in that I had been an institute director, so I sort of understood how NIH normally functioned from the inside, and I'd been a long time applicant and grantee on the outside. And starting in end of January, early February, early in the current administration, things at NIH started getting strange. So meetings were being canceled and grants were put on hold, and I realized at that point that I needed to track what was going on just from my own understanding of what was happening, and then discovered that there was a big interest, actually both outside and inside NIH about what was going on because the communications were all so screwed up. So I spent the whole year sort of tracking things, mostly using public databases. The NIH Reporter, a lot of the grant data is online, but also in contacts that I had inside NIH, either people I knew before or people who I came to know over the course of the year, and was just trying to keep track of what was happening, where things were headed to the best of my ability to tell, and sort of tracking all the different changes in policy and their potential implications that were taking place over the year.
What kinds of things did you start to notice?
Well, so the first step was a freeze on all federal grant making, which was unusual. And that was litigated and deemed to be illegal. And then NIH continued basically to do it anyway. There was a Friday afternoon memo about the indirect cost rate policy being changed to something that was pretty draconian and didn't make any sense, that came out and caused a lot of institutions to get very worried about the implications of that. And that also was litigated pretty quickly. There were, as I mentioned, meetings canceled. So the way a NIH grant is reviewed, it first goes to a study section, and then it goes to a National Advisory Council before it can be considered for funding. And it turns out that both study section meetings and the advisory committee meetings are subject to the Federal Advisory Committee Act, or FACA, which means the meetings have to be posted in the Federal Register 15 days before they occur. And that process was stopped. So the meetings couldn't take place. So grant applications that had been submitted weren't being reviewed. And even once they were being reviewed, the advisory committee meetings weren't taking place. So to a pretty close approximation, any part of the process that could be disrupted or tampered with was being disrupted or tampered with. So it was a lot to keep track of, and to try to figure out what the implications were was really a challenge. But the only way to do it was, getting the best data you could and trying to follow it.
Back to what you said about indirect costs, because that's been a major part of the conversation. Can you give us an explanation of what that is and what the changes were?
Sure. So NIH grants and most federal grants cover the direct costs of research, so salaries and supplies and that sort of thing. But going back to the 1950s, I believe, the government realized that there were indirect costs, which was a terrible name. But basically, in order to do research, you need a laboratory that's heated and cooled and air conditioned and cleaned, and you need libraries and you need, other sorts of infrastructure, computer systems and so on that are crucial for doing research, but are very hard to attribute to any particular project. So the federal government developed a system which was actually, in my view, pretty efficient, where each institution would negotiate with the entire federal government an indirect cost rate, basically by taking all their indirect costs across all of the awards that they get and just divvying them up based on a percentage of the direct costs. So it was never intended to make sense on an individual grant basis, but it did make sense on an institutional basis. So every 4 years, Hopkins and other places negotiate an indirect cost rate, for the different schools. And that number is then applied according to the direct costs with some adjustments to give a measure of the amount of indirect costs that can be recovered. And the average nationally for those indirect cost rates is between 55 and 60%, although those have been capped for quite a while. The new proposal was that the indirect cost rate would be 15% across the board. So that was a 2 to 3 to 4-fold, depending on how you do the math, drop in indirect costs, and institutions just, that's just not sustainable. I mean, those costs are real and the money has to come from somewhere, and institutions would need to find ways to cover them, but it was going to be difficult, if not impossible.
Do we know anything about how they arrived at that number, 15%?
So as far as one can tell, it was based on rates that private foundations have negotiated. So the Gates Foundation and other foundations say, we will offer you a grant, but we'll only pay 10% or 15%, not the same as your federal negotiated rate. And institutions have the option of declining a grant, which sometimes some institutions do. They say, we won't take a grant if it doesn't have full indirect cost recovery. But in other cases, it was better for the science and for the faculty and for the generation of knowledge to accept the grant and just figure out a way to cover the missing indirect costs by some other mechanism. But that's on a tiny scale. So that's, way less than 1% of the NIH funding that most institutions get. So covering those costs was manageable. But if you scale it up to the NIH funding level, it wasn't. So I think they said, well, if you only charge the Gates Foundation 15%, why should the federal government be charged 55%? So that was the argument. That's where the number came from, or at least what's where they said the number came from.
Why should the federal government pay that if individual foundations are not?
Well, because without the federal government being involved, the foundations wouldn't have any research infrastructure for their research to get done. It's, is the federal government getting sort of ripped off relative to foundations? They're certainly paying some approximation to the full amount, whereas foundations are getting a discount, basically. But because of the scale, it doesn't work unless the federal government is paying a reasonable amount. So you could rejigger the whole system and make it uniform across the board, but the only thing that would happen is that the indirect cost rate would go from 55% to 55.5% to cover the increased expenses associated with private foundations, and less science would get done.
Yeah, and I think that's kind of where I was headed with this conversation is that, for a long time, it has been in the federal government's best interest to contribute to this pipeline of research, to keep this ecosystem going. Now, all of a sudden, they're not, and this has real implications. And so can you talk a little bit about, maybe exactly what does NIH research do? What has it accomplished? And kind of what are we looking at now if it's not funded?
Sure. Well, let me take a step back first. I mean, the whole origin of this idea of the partnership between the federal government and universities goes back to World War II and a remarkable document called Science, the Endless Frontier that was written by Vannevar Bush, who was an MIT engineer who was very much involved in science planning during World War II. And he was asked, actually, he got President Roosevelt to ask him to do an analysis of how the federal government should fund science in peacetime. And he came up with this model that, which was based on his experience, is you just let universities do curiosity-driven research about things that they want to study because they're interesting. And then if you're the government or private industry, you can use all these discoveries because they're freely published and so on. And it turns out that it's much better than doing targeted research, because a lot of times he discovered during the war was, we need a widget that does this. And they could have had a contract that would have taken 2 years for somebody to develop a widget that does that. But there oftentimes was already academic research where somebody made a widget that does that for a completely different reason, but it was just there to sort of pick up and plug in. So NIH developed in, more or less following that period of time, doing this partnership with the federal government and universities, funding health research and training sort of across the board. So everything from very basic research, the basic fundamentals of biology, the genetic code and physiology and genetics and all the things that are sort of the underpinning of a lot of understanding of medicine and health, to more applied epidemiology, clinical trials in specific areas, particularly clinical trials where there's not really a good niche for private industry to step in, because there may not be a drug per se that's involved, but it's a question of what sort of interventions might work and, do they really work? I mean, one sort of classic example is the Framingham Heart Study, which was a very long-running NIH program just looking at the citizens of Framingham, Massachusetts, and keeping track of them year to year about their health and their behaviors and so on. That led to basically the discovery of the importance of blood pressure and cardiovascular disease, and eventually cholesterol levels and cardiovascular disease, which led to the development of statins and so on and so forth. So it's a sort of the underpinning across all of medicine in a lot of ways. And there's something like 98% of the drugs that are developed have a traceable path back to NIH-funded research. It's really a partnership where NIH funds research in universities, and universities go off and do stuff, and occasionally are things which are connected to commercialization opportunities and getting things out to the public. And then private industry steps in and, takes the risks and does the clinical trials to get their drug approved through the FDA and so on. In public health, there are lots of interventions that have been developed through NIH funding, again, that aren't necessarily pharmaceutical based, that have had a huge impact. Vaccine testing and development, continued efforts to identify emerging diseases and develop early interventions that can help. And then on the training side, because of the way university research works, most of the research is done with trainees, so with graduate students and postdoctoral fellows and so on. And they, in addition to contributing to the research, get trained about how to be researchers and how to do science, and bringing, the combination of what they learned and their own ideas and interests to be the next generation and the generation after that of scientific progress. And that's really been a powerful driver for progress over the 60, 70 years.
So what does this look like now? I mean, how much of NIH still, I guess, exists? What percentage of things actually happened this year? What is going to happen next year? Where are we now?
Over the course of the year, NIH was very slow in making grants. I was doing a lot of analysis of sort of benchmarking relative to last fiscal year or the last 10 fiscal years, and they were way behind where they needed to be. They had about $36 billion worth of funding that they needed to get committed. And by mid-July, I was like, there's no way they have time to get the money out the door. And then they picked, the NIH staff really sort of picked up the pace. They were finally given permission to pick up the pace, and got a lot of funding out the door in the last couple months. So at the end of the year, it looks like they got all the money committed. There was a little bit of accounting shenanigans that went on, so that's there were fewer projects than were funded that you would have expected otherwise because of the way they funded some things. But overall, at the end, it came out much better than I thought it would be. Although even the delays are not without consequence. So if an investigator has a multi-year grant, usually the way that works is they get a new allotment every year based on submitting a progress report and so on. And those grants were delayed. The continuations were delayed 3 or 4 or 5 months when people didn't know whether they were coming or not. So there are lots of stories about people who fired staff or people who moved on to other positions because they weren't sure whether they were going to have funding or not, or graduate students who weren't taken into labs because they weren't sure whether they had funding or not. Even though it eventually came through, there was still damage that was done. So now we're sort of in a quiet period. The federal fiscal year starts on October 1st, and there's normally kind of a quiet period at the beginning, but now with the government shutdown, it's really quiet. So nothing is happening now, but the expectation is, NIH has clearly been laying the groundwork to be able to terminate grants based on lack of alignment with current agency priorities, which, doesn't have to do with scientific priorities per se, but, some of the anti-DEI and anti-vaccine hesitancy and autism areas, which have been controversial for whatever reason. Government has been laying the groundwork to be able to terminate those grants more legally than they did last time. They lost a couple of lawsuits because they terminated grants illegally, and they've learned the lessons and are going to not let that happen again, I think. But if there's one lesson I learned from the last year is you never know what's going to happen. I mean, I sort of pride myself on keeping my eye on the horizon, and that used to mean, looking a year or two out. And for the last 10 months, it's meant Friday at 5 was sort of the horizon that I was comfortable with, because there was something new that would come up. The NIH is also short-staffed. They've lost a lot of people through firings of various sorts. As I said, there are 27 institutes and centers right now. 13 of the 27 have acting directors because directors have been fired or have left. So there are lots of key positions that need to be filled. It's not clear how that's going to happen. My 7.5 years as institute director was the best job I ever had, but it was really hard. I mean, it's just a lot to running a $2 billion operation with a pretty big staff and lots of stakeholders and complications. Takes a lot of scientific knowledge and willingness to learn of all the things about, NIH is just a complicated place. Managing people and communicating and dealing with Congress and dealing with your colleagues at NIH and dealing with the scientific community and worrying about training and, everything else. They're complicated jobs. And I'm very worried that getting the quality of people that they need is going to be a challenge, to put it mildly.
Is this a shrinking footprint of funding, or is it a shifting allocation overall?
Probably some of both. I mean, one of the ways that NIH got the grants out the door at the end of the year was they used a device called multi-year funding. Normally grants are funded sort of 1 year at a time, but NIH funded a bunch of grants all 4 years and out of the 2025 fiscal year budget, which is basically just an accounting trick. So you're spending the money, but you're actually funding fewer projects. Because if you hadn't done that, instead of funding a 4-year grant out of one fiscal year, you could have funded 4 grants for 1 year each and then paid for the rest of them from future appropriations. So I think that's shrinking. That's going to shrink the number of projects and the number of investigators who are funded. The priorities are shifting in ways that are, some of which is obvious, some of which is not so obvious. There was an executive order that claimed the authority to put political appointees in charge of making final funding decisions, which, having non-scientists making these decisions without the requisite knowledge, is certainly concerning. That hasn't played out yet, and I'm sure it will be litigated once it starts to happen, but how that plays out is on my things to worry about list.
What might this mean for the overall landscape of scientific research in the United States?
Well, I think the biggest thing is sort of an intangible, and that's just uncertainty. It used to be there was a sort of trusted partnership between academia and the government, of the NIH over funding. It's not like getting NIH funding was easy, but the rules were pretty clear. And if you had good ideas and worked hard and write good proposals and everything else, you had a reasonable shot of getting funding if you were persistent enough. And now a lot of that sense of understanding the rules of the road is sort of gone, where people did all that, they got funded, and their grant was terminated for some reason that was deemed by the court to be arbitrary and capricious. And that uncertainty worries me a lot, because it's just, science is a multi-year, long-term sort of proposition. And when you're not sure that you're going to have money that was promised to you the next year, it's very easy to sort of change your strategy and hire staff in a different way and just sort of always be prepared to having a shutdown plan for everything instead of worrying about understanding the secrets of nature and improving public health and all the things you want to be worrying about.
I know there's some efforts of negotiation, and one of those is around what's called the FAIR model. Can you talk about the FAIR model?
Yeah, so the pushback about the indirect cost change was both legally and practically pretty strong, and there was a model that was put together by a bunch of groups called the FAIR model. And the idea was basically, in some ways it's going backwards, but it's a way of making something politically workable, whereby for each grant, there's a way of allocating different categories of indirect costs in a way that seems fairly sensible and might be workable, not be too cumbersome administratively, depending on how it's implemented. So the idea is, if all of this works, is that for each grant, you would be able to say the direct costs are X and the associated indirect costs are Y, where the indirect costs actually make sense with the actual costs of the project. So if it's a purely computational project, then you don't need lab space and things like that. So you shouldn't necessarily get reimbursed for indirect costs associated with that. So the whole thing would make sense. Now, in the past, the way that was handled was it was always averaged across the entire institution. So it doesn't make sense for a computational grant to get full indirect costs. On the other hand, for laboratory expenses, they were getting less indirect costs because of the computational things that were going on at the university. So it's really just an accounting game. But it has the potential to be something that's transparent, that anybody can look at every grant and say, this makes sense or this doesn't make sense. And the hope is that the administration and Congress and the scientific community will get on board with this as a model that's rational and transparent and defensible. Probably more work. The previous model was actually a good sign of government efficiency rather than inefficiency, but we are where we are. So I'm optimistic that it gets done and that it gets implemented in a way that's not too cumbersome, so investigators don't have to spend too much of their time trying to deal with getting the indirect costs right rather than doing the science, but we'll see.
The changes that you see being made now, and I know, again, given that uncertainty seems to be the big theme here, are they forever changes? Is this something that, a few years from now could be turned around and reset? What are we looking at here?
It's not a switch. I mean, it's not as if the policies were reversed, everything would go back to normal. I think real damage has been done. As I said, sort of the trust component is definitely different than it was. People have been lost. Progress has been lost. It's a lot easier to tear things down than it is to build things up. But the sooner things get on a more sensible path, the easier it will be to rebuild whatever the structure looks like. I'm not even sure. I mean, I'm actually involved with a couple of groups that are starting to organize discussions about sort of NIH 2.0 of, if we had to start from scratch, what would we build and why, and who needs to be involved in shaping that vision. On the one hand, kind of exciting to think about. On the other hand, it's kind of depressing to have to think about it. So the old system wasn't perfect by any stretch of the imagination. There were lots of reforms that were possible and even things that I was working toward, but it was pretty good. And, just ripping it down because of some other agenda is pretty just devastating to me.
Well, Dr. Berg, thank you so much for being here with us and walking us through this. And, maybe at some point you can share, the version of NIH 2.0 with us as well. Thanks so much.
Thank you.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Michael Bonfils, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production coordination by Catherine Ricardo. Analytics by Elisa Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.